Hi, I'm Danielle Matias at Caring Medical Florida, talking to you today about shoulder impingement. It often overlaps with a lot of other shoulder conditions, such as a rotator cuff tear, bursitis, acromioclavicular injury, and even joint instability of either the acromioclavicular or the glenohumeral joint. So we're actually going to cover all of that today as we talk about shoulder impingement. In our office, we see chronic conditions, people that have had chronic shoulder pain, chronic shoulder impingement, and they've tried everything. They've tried all the traditional therapies, physical therapy, maybe chiropractic, acupuncture, dry needling, cortisone injections, maybe even surgery. We see all the people that have pretty much failed all of those modalities. They still have this chronic shoulder issue. It's affecting their way of life, maybe even affecting how well they sleep at night, and they're looking for answers. What we often find in our office is that people that have this unresolved chronic shoulder impingement often have an instability component to their pain. That does not mean the shoulder is so unstable it dislocates all the time or it feels like it's going to fall off. Oftentimes it's more of what we call a micro instability, where the shoulder is not falling out of joint all the time. Maybe it is subluxing a little bit, but it's just unstable enough that it's stressing out your tendons and all the surrounding tissue. Here is actually a really good diagram of that. So this is the glenohumeral, called the ball and socket joint of the shoulder, and this is that whole network of ligaments I was talking about that basically hold that ball and socket together. Really, if we want to get technical, it's not even a true ball and socket joint. It's not like you have this big bony socket that stabilizes the shoulder. It's more like a golf ball on a tee, if you can imagine that, and then it's just so reliant on soft tissue to help keep that golf ball on the tee. So that's what these ligaments are, and then above here is that AC joint and all those separate ligaments. If these are stretched out, they don't even have to be torn. If they're stretched out to the point where they're lax and they're allowing for that excess shoulder movement, what's going to happen is that, quite frankly, that golf ball on a tee, that golf ball is going to wobble on the tee to some degree. That, in and of itself, is going to make all your muscles around your shoulder work harder. They're going to spasm, they're going to tighten, they're going to try to help hold that shoulder together and try to provide some temporary stability. Over time, the more chronic that gets, the more those tendons are going to get stressed out and they're going to start to degenerate and even tear simply from just being overworked, that extra strain from that shoulder being unstable. When that happens, here's that supraspinatus tendon that actually will come right through this canal here and attach over here. If that becomes inflamed, irritated, thickened from degeneration, what happens then is it starts to take up more room in this little tunnel. So you have this tunnel between the ball and socket, we'll just say, and the AC joint, and that's where that supraspinatus tendon lies. At rest, like with your arm by your side, that tunnel is wide open. You've got room for the tendon, you've got room for that bursa that sits on top of it. But if that tendon is swollen and it's thick, or that the ball is kind of hiked up more from instability, that tunnel gets smaller and smaller. So you don't have as much room. And then when you go to put your arm up, which is a position that naturally narrows that tunnel, well, if everything is taking up more room, it's going to easily get pinched or easily get smashed every time you raise your arm up from your body. So that's what's happening here. Like when you raise your arm up, this gets smashed and it really, really hurts. Honestly, you kind of dread using your arm. You might even start to use your scapula more to help alleviate the pain, and this actually can set you up for a frozen shoulder long term if it goes on long enough. The other thing is if that AC joint is a little unstable and maybe that collarbone is moving more than it should, that can smash down on that tendon as well. It's not as common, but it can happen. Here's a picture of shoulder impingement with that bursa. So here's that, we call that the glenohumeral joint. There's your tendon, there's the bursa on top of it, all fitting in that tunnel I was just talking about. But when you raise your arm up and that tunnel narrows, these structures are at risk of getting pinched. That's what impingement is, if the joint is unstable or that tendon is thickened from degeneration or both. Bursitis happens when that small ball of fluid gets more fluid in it. It gets bigger, it takes up more space, again, putting you at risk of impingement. Chronic bursitis, people that have had bursitis for years and haven't been able to get rid of it, oftentimes we find is related to an underlying rotator cuff issue and joint instability. And you can do all the cortisone shots in the bursa that you want. Will they help you temporarily? Absolutely. If it resolves your bursitis, those are the patients that never end up here. We're talking about chronic cases where it just hasn't gone away. They might keep doing cortisone shot after cortisone shot, and it helps for a while, but then the amount of time it helps becomes less and less and less as you continue to get the cortisone. All the meanwhile, you have this underlying joint instability, this underlying tendon problem that slowly gets worse and worse. In some cases, people may have what's called a type 2 or a type 3 acromion. What that means is that this part here, this bone, might be, instead of flat, more angled down or even kind of sharply angled down. When that happens, more pressure can absolutely get put on that bursa and that supraspinatus tendon, causing inflammation and causing injury. In cases where people have this and they have bursitis, it does not mean that they always need surgery, although sometimes that is true. I had a patient recently who actually had an MRI that showed that they had a type 2 acromion, where basically it was just a little bit more curved down. The patient also had a labral tear and a very unstable shoulder. We ended up doing several rounds of PRP prolotherapy to treat the labral tear and get the shoulder to be stable, and the patient did great. The patient got back to weightlifting, they could trust their shoulder. We also have had them do some hanging as part of their rehab once their shoulder was stable enough to try to get your shoulder blade back a little bit so it's not so hunched over and curved on that shoulder. I present that case as an example because not everybody needs surgery for those kind of things. If you are somebody that has a chronic shoulder impingement and you've tried everything and you just haven't been able to get it to be resolved, check out our website. We have a lot of research and a lot of data on there that we'd love to share with you.